been quite a long time since we had our last session. So let me welcome our moderator, Dr. Eduardo Tinhay, and all the other consultants who are present in this conference. So our topic will be today is about a part of the special catheters, which is namely intravascular ultrasound or IVUS. So for my outline, so you'll start off with the principles of IVUS imaging, the arterial anatomy on IVUS, some image artifacts, and how to measure different kinds of plaque morphology in the clinical applications, and some case. So what is IVUS? IVUS is an imaging modality that a user that uses the catheter with a miniature ultrasound probe to allow viewing of the inner walls of the blood vessels. So during cardiac catheterization, an IVUS coronary catheter is advanced over a guide wire beyond the target lesion in this picture, and subsequently a pullback of the transducer tip through the lesion or segment of the interest is performed. So what are the equipment used in IVUS? So just to be familiarized with anyone who is the first time seeing one. So first, we use an intracoronary ultrasound catheter. Usually they have an outer diameter of around 2.6 to 3.5 French. So these are very small devices that are suitable for examination of a more distal coronary locations. And they permit examination of almost all stenotic segments prior intervention. And the smallest catheters can be placed through a large lumen 6 French guide. So although some prefer to use a 7 or 8 French. So the next one on the figure B, that's called a pullback device. So the transducer pullback can be performed either manually or a single using a motorized pullback device such as this one. So it withdraws the catheter at a constant speed of around 0.25 to 1 millimeter per second, but most frequently at 0.5 millimeter per second. So there are several reasons for the routine use of an automatic pullback. So first, they start using in every IVUS study the fiducial point, such as a prominent branch or an outer landmark, and they start recording the pullback, the pullback or a sequence from that point. And the entire imaging run can be systemically reviewed offline. So after the study, you can review it frame by frame. Second, there's a systematic recording with a motorized pullback, which allows a review of studies systemically at a later date without having to guess in which direction the catheter was moving at a particular point in time. And third, during interventional procedures, a very important use for the automatic pullback is that we can have an accurate and reproducible method of measuring the lesion length. So lastly, on the figure C is the imaging console. So it's the hardware and software necessary to convert the IVUS signal to the image and monitor and recording devices. So how does IVUS works? So a catheter pulls back to a lesion or an area of interest and results in a series of tomographic cross-sectional images of the vessel. So the catheter has a transducer, this one, that is mounted at the tip of the catheter. A transducer converts one type of energy to another, in this case, electricity to sound. An ultrasound signal is produced in the transducer by passing an electrical current through the piezoelectric crystals and material that expands and contracts when electricity was given. So the images are formed through interpolation. So the density of the structure of the ultrasound in contact with it will determine whether the sound will be reflected or pass through the structure. So this is referred to as acoustic impedance. So after that, the reflected ultrasound returns to the transducer and is converted into an electronic image. The transducer spins at high speeds within the vessel while pulling back into the catheter. it takes pictures in 360 degrees. So this is an animation that demonstrates how the ultrasound catheter rotates to create a lighthouse effect, sweeping the ultrasound beam perpendicular to the catheter. The ultrasound beam or sound waves produce cross-sectional images that you can see the three layers of the vessel wall. So the intima in the normal artery are very little of the intima can be seen, no? But sometimes a thin layer will be seen due to some of its composition of elastin fibers. The intima is where atherosclerosis occurs. For the media, it is seen as a thin dark layer. So it is dark due to its composition of being made up of smooth muscle layers and very little ultrasound is reflected. And next is the adventitia, which reflects a fair amount of ultrasound due to its composition of elastin fibers and connective tissue. It will appear white or bright white on ultrasound images. So here is an example of the different hertz or megahertz of frequency that we use. So usually catheters way back they only emit at around 20 to 40, but now they're available up to 60. So these three images show the difference in image quality between the catheters. So the higher the hertz, the better detail or resolution. So this is the standard display of an IVUS system, which consists of cross-sectional individual images on the right, and the motorized transducer pullback and digital storage cross-sectional images allow longitudinal image on the left. So the sawtooth patterns that you see here is caused by the change in vessel size during the cardiac cycle and can be reduced by electrocardiogram triggered image acquisition. So for the anatomy in IVUS, first discuss the lumen. So at frequencies of more than 20 megahertz, flowing blood exhibits a characteristic pattern of echogenicity. So observed as a finely textured echoes in a swirling pattern. So this blood speckle assists in image interpretation. It helps to differentiate the lumen and the vessel wall and can confirm communication between a dissection plane and the lumen. So blood speckle is more prominent at higher imaging frequencies, which may interfere with delineation of the blood tissue interface. So flushing of the vessels, just in this figure, using saline or contrast medium during IVUS imaging can help to differentiate lumen and vessel wall. So next is the vessel lumen and arterial dissection. So this is just an example of an arterial dissection. Note that after flushing with saline, it helped in differentiating the communication between the dissection plane and the vessel lumen. So depending on the size of the artery, adjacent structures including arterial side branches, cardiac veins, and the pericardium can be differentiated. So in the left figure, the pericardial space here is shown in the blue color, and an arterial side branch is also seen at the 6 o'clock position. So during pullback to the vessel, our arterial side branches appear characteristically and at the periphery of the image, and then they join the image vessel as seen in the right figure. So the cardiac veins run parallel to the artery or cross the artery, but characteristically do not join the image vessel. So in addition, they can be differentiated by the systolic compression. So most commonly, we use these adjacent structures as landmarks during IVUS. For vessel bifurcation, because of the unique hemodynamic properties, vessel bifurcations are predisposed to early or eccentric plaque development. So in IVUS images, the proximal segment of the side branch can often be visualized during pullback of the catheter through the main vessel. However, because of the eccentric position of the catheter relative to the side branch, these images are difficult to evaluate. So an example here is the aorto-ostial bifurcation. So the vessel wall of the aorta here uh, appears thickened and has different echogenicity. So which may be an artifact secondary to the oblique position of the catheter. So let's go to image artifacts. So just to be familiarized, so one of the more common artifacts is the guide wire. So as you can see here, using the monorail catheter, the guide wire lies outside the transducer and can cause heractis artifact. So it is distinguished by a narrow angled shadow. So depending on the settings and operating frequency, these artifacts can be dark, as in the left, and echo dense on the right. Now, this is quite important. This is called the ring down artifact. That's usually observed as bright halos, like this one, of variable thickness surrounding the catheter. They are caused by acoustic oscillations in the transducer, which can result in high amplitude ultrasound signals that can obscure the area immediately adjacent to the catheter. So ring down artifacts create a zone of uncertainty. So some programs like the time gain compensation or TGC can be used to decrease this artifact. And excessive ring down suppression can reduce the signal from two targets close to the catheter, which is a downside to it. And another on the right is in electronic systems, the transducers are surface mounted and ring down is partially reduced by digital subtraction of a reference node. It is incorrectly performed during subtraction and has the potential to remove actual information or introduce a false border close to the transducer. So in this figure, the right panel or image shows that the reference lumen is usually the reference lumen is more the proximal, normal or relatively healthy part of the area. And while image B shows the lumen at the lesion. So after digital subtraction, you can see that the lumen appears to be bigger, but they're actually the same. So, and another kind of artifact you usually see is called the non-uniform rotational distortion on NURD. So it arises from an even drag of the drive cable of mechanical catheters, resulting in cyclical oscillations or rotational transducer speed and observed as a visible distortion of the image. So NURD can occur for a number of reasons, such as presence of acute bends in the artery, tortuous guiding catheter shape, and kinking of the imaging sheet or small guider catheter lumen. So this is a frequent and reversible cause is excessive tightening of the hemostatic valve. Another artifact is the slow flow, which is the intensity of the blood speckle increases exponentially as the blood flow velocity decreases. So therefore, when there's a flow stagnation, often the most evident is seen when the catheter is advanced across a tight stenosis. This can limit the ability to differentiate the lumen from the echolucent tissue, including the subplaque, the intima, or the thrombus. So in this situation, flushing of the vessel with saline or contrast is particularly helpful for the differentiation of the lumen and the vessel wall. And another, during the cardiac cycle, the IVUS transducer undergoes longitudinal displacement as much as 5 millimeter in the axial direction. And the changes of angular orientation of the catheter relative to the vessel. And in addition, the diameter of the coronary arteries undergoes drastic changes during the cardiac cycle. So in the normal coronaries, such as on the left figure, the luminal diameter is maximal in systole. And although flow is maximal in diastole, there is resistance to the flow in the small intramyocardial vessels, which is minimal. So during systole on the right and diastolic on the left, are shown in the upper part of the figure. So the difference in size and shape of the vessel is illustrated. So in contrast, the cyclical pattern of artery size is reversed at the site of muscle bridging, as in on the right panel. So here, the artery size reaches a minimum during systole, smaller, and causes a contraction of the muscle surrounding the vessel. Next is a catheter obliquity and eccentricity. So your geometric distortion can result from imaging in an oblique plane. So it means not perpendicular to the long axis of the vessel. And the transducer obliquity is especially important in large vessels and can result in an overestimation and reduction in image quality. And lastly, this calcium is an important part of the atherosclerotic plaque, and IVUS has a high sensitivity to its detection. However, almost all IVUS energy is reflected by calcium, causing a characteristic signal dropout. So here, you can see the calcium is very wide, but beneath it, or there's an echo dropout, which limits the visualization of the artery. So for the IVUS measurements, so again, bright, dark, bright. So this is a three-layered appearance as seen in the image with corresponding anatomy as defined. So IVUS represents an imaging catheter in the blood vessel lumen, and histologic correlations with intima, media, and adventitia is shown. So the media has a lower ultrasound reflectance owing to less collagen and elastin, and compared to the neighboring layers. And follow that, the intimal layer reflects ultrasound more strongly than the media, and there is a spillover in the image, which can result in slight overestimation of the thickness of the intima and a corresponding underestimation of the medial thickness. So later on, we'll go over this definition. So just as a lumen cross-sectional area, which is the area bound by luminal border, the minimum and maximum lumen diameter, which is the relatively more important, and lumen eccentricity as calculated as such, and lumen area stenosis. So we will go over this in a few more slides. So let me first discuss the syntax to trial, which is a multi-center open label study involving 22 European countries. So they compared the use of IVUS in syntax 1 is only about 4.8% compared to the syntax 2 where they use it at an alarming 84.1%. So they found out here that the PCI following syntax 2 strategy demonstrated a statistically significant improvement in patient-oriented composite endpoints such as all-cause death, stroke, MR, or any revascularization at 7.2% versus 26.7%. This is statistically significant. So in determining lesion significance, there are two ways in assessing lesion significance using IVUS. So first, percent lumen area stenosis and minimum lumen area or MLA are used. So when calculating the minimum lumen area with IVUS, it requires only one measurement. So the MLA or the cross-sectional area of the lesion at its tightest point. The one number is compared to standard guidelines. So for the left mean, a value of less than 6 millimeters squared is considered significant flow limiting. And although FFR is the gold standard to assess lesion functional significance with a value of less than 0.75. So there are 3 randomized clinical trials such as the DEFER, FAME, and FAME2 trials that establish FFR as the gold standard to assess the significance of a non-left main coronary artery lesion. So many studies have attempted to identify the IVUS criteria that are equivalent to FFR or non-invasive ischemia testing And although the IVUS minimum lumen area was the parameter that best correlated with ischemia, the reported thresholds of IVUS MLA cutoffs range from 2.1 to 4.4 meters squared for the non-left main lesions. So for the Asians, they have a smaller cutoff, which is most commonly at 3.0 millimeter per squared. Okay. So as a test, so is this lesion significant? So here with the left main reference point, which is the relatively normal part of the left main, is 4.67, and here the MLA was brought down to 4.84, which is less than 0.6. So definitely this lesion is significant. So the gold standard for here is for the patient is to undergo a surgical consult also. Next, so percent lumen area stenosis is not a widely used measure of lesion significance. IVUS also uses the proximal reference area and the tightest point to determine lesion significance. It is a measure of obstruction. This gives the lesion significance by measuring the lesion across the cross-sectional area compared to a reference lumen cross-sectional area. This calculation depends on two measurements. So the cross-sectional area of the reference lumen and the cross-sectional area of the lesion lumen. The reference lumen area represents the relatively healthy area of the vessel, much like when measuring the QCA during coronary angiography. There is another measurement that you may hear, which is called plaque burden. Though it's commonly used in the past, it is generally used for research purposes. In looking for lesion significance, we measure reference lumen to lesion lumen. To measure plaque burden, we are going to measure the media and the lumen at the point of the greatest disease. Plaque burden can occur in the absence of any obstruction or flow limitations. Meaning if there's a significant plaque burden, sometimes the lumen is still not obstructed. So measuring vessels with positive remodeling may not be relevant as there may be no flow limitations. So example, if the vessels has positive remodeling, this won't actually reflect the size of the vessel in a more normal area. It will artificially inflate the proportions. So sometimes lesions really are homogeneous, or most of the time. And usually there are a combination of these kinds of plaques. So that's why they are called mixed plaque. So fatty or soft plaque tend to have a high lipid content and mostly cellular lesion. Some fatty or soft plaques that have a zone of low echogenicity may preclude a layer of necrotic cells, thrombus, or intramural hematoma. The term soft reflects more to an echo pattern and not the property of the plaque. On the second hand, fibrotic plaque tend to be more heterogeneous with mixture of soft, fibrous, and calcific plaques. And this type of plaque represents the majority of atherosclerotic lesions. Calcific plaques tend to be referred to as a hard plaque, and none of the sound wave pass through the calcific lesions, and it appears bright white with complete shadows behind. So when do we use IVUS? So primarily, the guidelines, the SCCA and the ACC mentioned that you can use IVUS in 3 different settings: pre-intervention, peri-intervention, and post-intervention. So for pre-intervention, and when planning for the patient, so you can determine the size, the lesion morphology, and lesion significance. And during peri-intervention, you can determine the stent apposition, post-dilatation if it's adequate, if you have any geographic miss or dissections. And post-intervention, among patients who underwent PCI, if you have instant stenosis, treatment strategies and complications. So using IVUS, you can also measure vessel diameter and lesion length in order to select the appropriately sized devices. So we use the lumen area to assess the lesion significance. And to assess the interventional device sizing, we use the diameter. So the shape of the cross represents the measurement of the diameter. And both the diameter and the length are both measured in millimeters. For IVUS diameter determination, measure the lumen at the reference point within the image slice with the largest lumen and the smallest plaque burden. And then size the interventional device accordingly. For the IVUS length, perform an automatic pullback to reconstruct the long view image interpretation, and then bookmark the proximal and distal reference points and measure the length between the two. So this is what we usually use to measure the appropriate length for the size of the stents. So for the recommended use of IVUS under the SAC consensus statement and guidelines, they term that it is definitely beneficial if the insertions with angiographic imaging is considered unreliable, such as in the presence of ostial lesions, segments with multiple overlapping vessels, or bifurcation lesions. And it also noted that this is helpful in assessing the vessel size and assess stent sizing during stent placement, and as well to confirm complete stent expansion and apposition, as well as lack of edge dissections and other complications. They also deemed that it's probably beneficial to evaluate the significance of left main lesions and assess whether revascularization is required, and determine it possibly beneficial to assess plaque morphology, decrease major adverse events in PCI, and reduce MACE in long lesions or long stents. However, there is no proven benefit to assess the severity of non-left main lesions in the absence of functional information. So based on the ACC, IVUS study showed a relatively high negative predictive value of around 72 to 96%, but on a low positive predictive value of 39 to 73%, indicating that although it may be acceptable to defer an intervention in selected situations based on MLA size, IVUS should never be used to justify an intervention. So IVUS has several limitations also. So features include signal dropout behind the calcium, prohibiting the visualization of the deep vessel structures. The physical size of the ultrasound catheter, usually around 1 millimeter, constitutes an important limitation in imaging severe stenosis and small vessels. In such vessels, the introduction of the catheter may cause dilatation of the vessel or the Doppler effect, which may limit the exact measurements. The spatial resolution of IVUS of around 150 micrometers allows detailed analysis of vessel wall structures. However, important structures of atherosclerotic plaques, in particular the fibrous cap, usually at around 60 to 100 micrometer, cannot be reliably analyzed. So the invasive character of IVUS explains this as a potential use in interventional cardiology, and it limits its particular application in asymptomatic patients. So next would be a sample case that we employed IVUS. So I wanted to use this patient. This is a previous patient with that. It's a 50-year-old male who recently had a positive CT angio and underwent coronary angiogram, which revealed a single vessel disease. So here, this shows that the patient is a guide chart shows that 70 to 80% proximal ALD lesion. So the second figure showed the placement of the IVUS catheter. The initial purpose of using the IVUS for this patient was to know the appropriate landing zones. So if it cover the ostium of the AD or not, and also the distal. So we've this is the initial IVUS run. As you can see, starting from the distal to the lesion with AD. The initial IVUS one.
Sabihin mo, Lars, baka siya na ako sa.
Yes po, Doctor.
Okay, go ahead. Last time.
Thank you, Doctor. So this is the let me run the IVUS again. So place the tip of the IVUS catheter to the mid LAD, and it showed that several five. Okay, wait, may stand. Yeah. So this is the initial IVUS run. So as I mentioned, we started at it's about the mid LAD, and it showed the fibrocalcific plaques on the proximal segment up to the ostial LAD. This is the diagonal branch. And here you can see so on the figure on the right, it shows the minimal lumen area, which is 3.11 millimeters squared with a plaque burden of around 77%. So we decided to place a 3 by 28 stent in this after this IVUS. So we had a repeat angiogram, which after deployment of the stent, and not shown here is that we also post dilated the stent using a 3.5 balloon up to 12 atmospheres. And the second image on the right, it shows our placement of the IVUS catheter. So during a second IVUS run, we shows that there's still a lesion distal, very tight lesion, distal to the stent. And however, the stent also has some good apposition, but there's some areas of under expansion also. We measured the tight lesion distal to the stent, and we noted the minimum lumen area 3.5 with still a 75% plaque burden. So this here in the bifurcation to the left knee. So we decided to deploy the second stent, which is also a 3 by 15 stent, overlapping the distal segment of the first stent, and post dilation using also a T5 NC balloon at 14 to 16 atmospheres. And or the final IVUS run, we can clearly see that the stent has a relatively circular shape, good stent apposition. It should be used to be the tightest area of the lesion. So in the mid LAD, post procedure, the MLA is now 5.36, and for the proximal AD, it's now up inflated at 8.7 millimeter squared. So for the final shot, shows that positivity flow and well apposition of the stent angiography. I think that would be my last slide. If there are any clarification or question you'd like to ask.
Thank you, Lester. I think we can ask some of the consultants present here if they have some comments or additions or maybe clarifications what they wanted to ask you about the discussion. Good morning, dear consultants.
Good morning.
Any comments? Any comments from the floor?
Lester, good morning.
Good morning.
Good morning, Ken.
Doctor. Can you
Go ahead.
help us differentiate what is the difference between malapposition and malexpansion?
Okay, so I don't have a picture, but so when you see the stent starts, or let me just show a previous example. So imagine there are stent struts here in the IVUS that is floating inside the vessels. So that means that there's the malapposition of the stent struts compared to under expansion, where some of the stent struts is not opposed to the vessel lumen. So that's for me the definition they gave regarding malapposition and under expansion.
Which do you think has a worse prognosis? Is it malexpansion or malapposition?
Malapposition for doctor is that you can develop instant stenosis in the area around outside the stent struts.
I agree with you, Lester. Thank you.
Thank you, Ken. Any other comments or addition? Lester, what do you think about the case you've shown? Is it a case of geographic miss or plaque shift distally after the stent?
I'm more thinking that it could probably be more of a geographical miss rather than this plaque protruding distal to the lumen, because in the angiogram prior to that, you can see that there's still some haziness or after the stent. So might need a longer stent to cover also that, especially it's in the angulation of the vessel, is just a more probably of having a more plaque.
Yes, but I think it could be a combination of both because
Yes.
Isn't it your IVUS showed more positive remodeling than negative remodeling? Your plaque burden is more than 70, right?
Yes, doctor, it's more than 70. So compared to the proximal reference lumen, so
so there's so much plaque to shift, and maybe because of the angulation and not so good flow initially, it's hard to discern what's there distally, right after the lesion, right, and after stent implantation. I think in that case, I think I was helped.
Definitely, sir. That's why I wanted this case because it shows the purpose of IVUS and the pre-intervention and the peri-intervention benefit. And if I may add also, the SCAI recently published an article that also extended the use of IVUS for during ctto lesions, the placement of the wire and especially those with renal concerns, and perhaps contrast-free PCI also using IVUS.
Okay, so you're saying about the growing number of use IVUS now has nowadays, including I think during ACS,
Yes.
wherein you're trying to determine the reason surrounding the ACS of the patient, especially if everything is quite obscure, unclear.
Yes.
That's one. And another is the CTO, wherein you have to redirect the wire and maybe look for the side branch or maybe look for the true lumen. That's another.
Yes.
Although these things are class 2A, I think, by classification, Lester. But these are growing number of indications nowadays. I'm sure other consultants here could give you more. Dr. Henry Chan, Dr. Timothy Lee. Do you have any other comments, questions, or additions? Thank you.
Thank you, dudes. I guess I'll go first before Henry.
Thank you.
Yeah. The other benefit of a motorized pullback, which I think Lester may not have mentioned, is our ability to accurately measure length. With the motorized pullback, the rate at which the IVUS catheter is pulled back is fixed. Therefore, you can measure length when you are planning your stenting. So in addition to knowing the diameter, you can also program your length. Whereas if you do a handheld pullback, since the rate at which we pull back manually is not really fixed and we cannot really measure it, then it will be helpful for plaque morphology and all of the other things that Lester mentioned, but a manual pullback will not give you length. I think it's good that Lester is talking about intravascular ultrasound because we do have IVUS available. Obviously, it will add cost to our procedures, but our center has lagged behind with other centers in terms of intravascular ultrasound usage. Our clientele obviously is not as well off as, let's say, Cardinal Santos or St. Luke's Medical Center or Medical City, and that has hampered our ability to provide this service for our patients. But I think in certain cases, it's very important to have and will help us achieve better results, not just short-term, but also long-term. As somebody who has not used intravascular ultrasound as much before, I have tried to incorporate it in my interventions more and more. And in particular, we're using it for borderline lesions and lesion characterization, as well as ensuring that we have good post-procedural success. So in vessels that are fairly large, it's not always clear angiographically whether you have full stent expansion or not, or whether you still have malapposition of your stents. So I think for large vessels, it's fairly important, especially for left main intervention. And then it might also be important for CTOs because as we all know, vessels that are chronically totally occluded are usually also not as dilated as it would be in normal flow. So we have a tendency to underestimate its size, and intravascular ultrasound sometimes can help us define the size of the vessels and achieve not just short-term success, but also long-term success. As we know, if you implant a small caliber stent in a larger artery, which has a tendency to happen in CTOs, then the chance of restenosis in the future is also higher. So I would certainly encourage all of us to consider the use of intravascular ultrasound in our patients. We also have fractional flow reserve No, these these tools are available to us so that we can practice what would be considered close to state-of-the-art intervention and provide our patients not just better short-term, but definitely a better long-term success. Thanks, dudes. Thanks, Lester.
Thank you, Doctor, for the wonderful comments. And
Thank you, Dr. Tim. Lester, just a comment about we did some IVUS run, and I noticed that we just depend on the assist of the
Okay.
IVUS. I think you and Eric should be the ones maybe guiding our techs, nurses, and trying to maybe locate, measure, and identify the landmarks that are to be taken note of, if ever. So that
we could manually plan it with the lesion, so we could actually better size the stent and assess the accurate measurement of the MLA compared to the automatic trace assist that we usually employ during IVUS.
yes, and although the number of IVUS cases or imaging cases are quite few nowadays, I think this could be a source of your research in the coming years, especially for the incoming CRF. Any other comments before we close? I think Dr. Henry Chan is not around, right, Lester?
Not
around.
Yes.
Okay. Any questions from the fellows to the discussant? Okay, if there's none, let's call it a day. Thank you very much for attending today's Interventional Cardio Conference, and good morning to everyone.
More. Thank you.